There were no shortage of health headlines this week, so for more insight, we turn to former FDA Commissioner Dr. Scott Gottlieb for an extended conversation. Dr. Gottlieb, thank you for the extra time. I want to
Thanks a lot.
Pick up on COVID. So the emergency is over, but does that mean we should drop our guard? I mean, do you still wear a mask?
I don't wear a mask right now, largely because prevalence is very low. There's just not a lot of infections circulating in the U.S. right now. Even though we're probably picking up only a small percentage of the actual infections that are happening, you see hospitalizations way down, and that's the best indicator, I think, of the overall impact that the virus is having and how much virus is spreading. We are going to see infections pick up as we head into the fall, and depending on what variants emerge and what impact they're having on Americans, people are going to have to make judgments about what precautions they take in their daily lives to prevent themselves from getting exposed and infected with the virus. Right now, the strains that are circulating, the variants that are circulating, even when people are getting infected, they're not getting very sick. And that's a combination of the fact that most people have been vaccinated and infected with the virus, so they have a tall wall of immunity that's protecting them, and also because the innate features of the virus that's circulating, these current strains, they're just not as serious infections as the prior variants that we saw in the past.
I know you're on the board of Pfizer. When we look at what the fall could look like, are you anticipating having to go get a booster shot?
Well, I think boosters are going to be made available, and they're going to be updated based on the new variants that are spreading. Right now, there's a plan that the FDA would meet at the end of June. They've announced that meeting. They're going to make a decision probably at that meeting to update the vaccines with a new variant. So it's going to be a new variant vaccine, much like we update the flu vaccine each year. We're going to probably be updating these COVID vaccines on an annual basis, at least for the foreseeable future. It's not clear what FDA is going to put in that new vaccine. It's probably going to be either 1.16 or 1.15. Those are two variants of the Omicron strain that's been circulating. They may put both of them into the syringe. My guess is they're just going to choose one, and I think if I had to take a guess today, I think it's going to be 1.16 because both of those variants are similar enough that they're going to provide cross-immunity. If they do make that decision, then the manufacturers, including Pfizer, are going to go out and manufacture those vaccines, and they're going to probably be available by the end of August or early September. So people who do want to go out and get a booster in the fall that's going to better cover the current variants are going to have that opportunity probably starting early September. And certainly older Americans, those at risk from COVID, I think it's going to be prudent to stay up to date with the vaccines.
So the end of the public health emergency means that the CDC has changed the way it tracks COVID data. So how will we know if there is an uptick? Who's going to tell us?
Yeah, look, we're not going to have as good data as we had in the past in terms of daily infections being reported. I think you have to look at hospitalizations. That's still reliable data, and it still does get reported. You also see wastewater data getting reported by the CDC that shows the overall background rate of infections that are occurring because the virus gets sloughed off into wastewater, and you can detect it that way. So I do think that we're going to get indicators of what's circulating and how much virus is circulating, even though we're not going to get the granular reporting on daily hospitalizations and daily cases that we got in the past. The bottom line is that data is just not going to be as reliable going forward anyway, so it's going to be less useful because most of the people who are getting sick aren't getting sick enough to go out and get tested and turn over those cases. And even people who do get diagnosed, in many cases, are getting diagnosed on home kits, home COVID tests, and so they're not getting reported to public health authorities where they're getting rolled up and reported to the CDC.
I want to also ask you about monkeypox. The CDC warned Monday about it, and they are tracking this cluster of cases out in Chicago. What should we be prepared for?
Well, I think we need to be prepared that this is a virus that's now endemic in the United States. Probably a virus that wasn't here at all is now a virus that we're going to have to deal with going forward. That doesn't mean we're going to have large outbreaks like what we had last summer, but it does mean that we're going to continue to have low-level spread and these sporadic clusters of infection like what you saw in Chicago where 12 cases emerged. There was also a case in Maricopa County. We're seeing monkeypox emerge in wastewater data in California. So it is spreading at a low level in the community. And so I think going forward, any physician who sees a patient with an unusual vesicular rash that isn't explained easily by another cause, another etiology, they're going to have to put monkeypox in the differential. Any kind of pustular rash that, sort of looks chickenpox-like is going to have to be considered. You're going to have to consider that it could be monkeypox if you can't explain it through another etiology, another cause. That's a real shame. This is a virus that didn't exist in the United States. We let it spread here widely a year ago, and now it's going to be very hard to snuff out permanently.
So some people call it Mpox now. You still call it monkeypox. I call it monkeypox. Why does it matter?
Yeah, I think people changed the name. The CDC and WHO changed the name to Mpox because they felt monkeypox was stigmatizing. I think over time we're going to see the medical establishment, sort of revert to the new name. I'm
Yeah.
kind of old-fashioned. I grew
Yeah.
up calling this monkeypox in medical school. It's hard to get it out of my
Yeah.
lexicon, but I think going forward you're going to see people start to convert.
Let me ask you about something we talked about on the broadcast in regard to this shortage of available and some essential medications, particularly injectables. One of the world's largest generic drug manufacturers, Teva Pharmaceuticals, which is based in Israel, said it's going to cut back manufacturing of generic drugs because of what you talked about, that low profitability. When you hear about a company making a call like that, what is it that the U.S. Private sector or government can do? Is there sort of an emergency reaction when a corporation does that?
Yeah, look, it's not just Teva. Acorn filed for bankruptcy. They made close to 100 different sterile preparations of drugs. In some cases, they were the sole provider of certain drugs like albuterol that's used inside hospitals, particularly for pediatric patients. We saw Lynette, another generic manufacturer, announce that it's going to be restructuring. So this business, this generic business, particularly for these complex drugs, these complex formulations, is not a healthy business right now, and yet it's a vital business from a public health standpoint. I do think there's things the government can do, but most of them are going to cost money. We're going to have to look for ways to try to provide more reimbursement for some of these hard-to-manufacture drugs. I think if you look at the IRA, the Inflation Reduction Act, which capped reimbursement to branded companies and took down their reimbursement, I think some of that money should have been used to cross-subsidize the generic industry. From a public health standpoint, that would have been prudent. If you're taking money out of the branded drugs and you think that those drugs are getting paid too much, we do know there's drugs that are probably paid too little in the marketplace, and we're going to need to find ways to pay more for them. That includes the sterile injectable generic drugs like the chemotherapeutics you talk about, certain IV antibiotics, and certain forms of IV opioids like morphine.
Well, the president is extremely proud of lowering the cost of certain drugs. What you're talking about was a pre-existing problem well before the Inflation Reduction Act, but you're saying it adds complexity.
It adds complexity because the Inflation Reduction Act, while not intended to price control these generic drugs, to the extent that it imposes inflation caps, so it prevents drug makers from taking big price increases, some of those drug makers that would have wanted to take big price increases might be a generic manufacturer, and it's not a big price increase on an absolute basis. You might be manufacturing an ampule of a sterile injectable drug at, let's say, $500 and losing money on it, losing a lot of money. You upgrade your manufacturing, you want to double the price to $1,000. At $1,000, even though it's a lot of money, it might still be cheap relative to the value that that drug's providing. But under the Inflation Reduction Act, such an increase you might not be able to take. So, because they put price caps in and cost controls, price controls on how much drug makers can increase the cost of their drugs, it doesn't leave a lot of room for the generic manufacturers to take price increases when they make real, genuine investments in the manufacturing that's going to help provide a more sustainable supply of these really important drugs.
I know you wrote a paper back in 2011 that you shared with us talking about a growing concentration back then of manufacturing in a smaller number of increasingly large suppliers. And when I read that, I heard echoes of the baby formula crisis, where we talked about these giants controlling an industry, and when there's a problem in one, it has a tremendous spillover effect. You think that's I mean, it's a different scenario, but is that sort of the risk level here that we're talking about, that one of these companies has a problem at a facility and it causes a domino effect?
Yeah, that's exactly right. It's an apt analogy, and it's an apt analogy also looking at this through the lens of FDA as a regulator with the platinum-based chemotherapeutics that are now in shortage and causing a lot of problems for patients. It was basically one large manufacturer in India that was taken offline because it had a disastrous FDA inspection with significant findings. There are only 5 manufacturers in the market for those drugs. This was one of the largest manufacturers, and now we see these distributed shortages. The problem is that these drugs are manufactured at such a low margin that the only way to do it profitably is to consolidate the manufacturing into very large facilities and produce at a tremendous scale. And then you get underinvestment in those facilities because there's not a lot of margin in these drugs, not a lot of money left over to reinvest in manufacturing. And so it means that if one facility that might be poorly maintained goes down, it could take out a very significant portion of the market, just like you saw with baby formula, where basically 3 companies controlled most of the market. That's the same thing for these generic injectable drugs. Sometimes there's a sole producer for some of these very important drugs. That's really no way to provide for a really critical public health intervention like a drug like this.
Dr. Gottlieb, always good to talk to you.
Thanks a lot.
Scott Gottlieb, former FDA commissioner and Pfizer board member.